Well, hi, welcome today. Rob Mortkin, Chief Medical Officer at Let's Get Checked, and we are joined by Dr. Brianna Guan. Really excited to have her hop on today to talk about her area of expertise and area of interest, and we'll get into that in just a minute, but her focus certainly clinically and knowledge base is focused particularly in the area of female health and female fertility. So that's where we're going to spend some of our time talking today. But welcome. Great to have you along. And perhaps you could just start off by telling us a bit about yourself. I know that you are a naturopathic physician. So maybe you could start there. Tell us about yourself and what that even means, your training, and we'll kind of jump from there.
Yeah, thanks so much for having me, Dr. Rob. So I'm a naturopathic physician and I specialize in female health and fertility, and I've been practicing for about 10 years. I got my medical degree from Bastyr University in Seattle, Washington, and that was a 4-year medical degree, with undergraduate before that. And after I had children and went through some hormone experiences myself, not being able to find the right answers and solutions led me to looking for other things. And that's when I found, wow, there's so much more that we can do to support women so that they're thriving and coming into a place of balance. And that really opened up my love for natural fertility support and supporting women to find strength within their cycles. And yeah.
That's great. And within your practice, your daily practice then, is it exclusively female patients that you see, and perhaps even ultra exclusively female patients who might be dealing with fertility issues only, or do you still see a broader range?
Most of my clients are women. Sometimes in fertility visits, the husband or partner will join. So I do some work with men around fertility. But most of my clients are hormone focused, so PCOS, endometriosis, irregular cycles, perimenopause, and fertility.
How do patients generally find themselves to you? And I'm sure it's a variety of different avenues, obviously word of mouth or friend of a friend, but really what I'm driving at here is, are patients finding you because they're often already struggling with fertility issues? Maybe they've been trying for a period of time to get pregnant and haven't achieved that. And I'm sure that's one path. Is it people that are perhaps considering entering into a period of their life where they want to start conceiving and they just want to make sure that, the ship is in order, so to speak?
Right.
What would be a common point of entry to your practice for a patient?
I see all of those points. I think the most common would be, a couple has been trying for like 3 to 6 months and they thought it was going to happen right away. And they're starting to feel a little bit anxious. And then they just want to make sure everything is, in good order and do everything they can to support that process. That seems to be the most common timing.
So I know in my own surgical training, the school of thought around fertility was generally when a couple or an individual has been trying for fertility with, absence of any birth control methods for about a year. if they've
Right.
been a year in and they're unsuccessful, then I think that would meet, I'll put it in air quotes, the criteria of infertility, or at least that's the point one would embark upon an evaluation. Does that criteria still hold true today? I mean, is it unreasonable for somebody, does somebody sort of have to sit on the sidelines for a year with their fingers crossed that it's going to work, or is it reasonable to enter into the process even earlier than that?
I recommend entering into the process many years before. That's the most ideal situation. But if you're going through the traditional medical model, it's really common to go in and then not really get much support or answers because there's no diagnosis at that point. So it's, take your multivitamin and come back, and, testing's not really offered. There's not a lot of education. With my clients, if they come in 2 years in advance and they have, minor imbalances or things are a little bit less than optimal, maybe she has really bad cramps or her diet is less than optimal, we can bring her to a state where she's feeling great, and her husband is thriving as well. And so then when they go to conceive, they've already laid a really strong foundation and they're going to be, have a better chance of success.
Yeah, that's great advice. I love the notion of being, somewhat preemptive rather than reactive. I mean, just as
Right.
an editorialization, I think obviously in healthcare, as a general rule, we have spent a long time being a very reactive profession, understandably so.
Yes.
But where I think a lot of us would love to get to is to be much more in that proactive stance, so that
Mm.
we're never even having to get to a reactive position.
Right.
Yeah.
Yeah, exactly. It's so much more fun to see people thriving versus, you can forego suffering, and who
Right.
wants to suffer?
Right.
Dr. Rob, did you ever hear that saying where people talk, couples spend like a year or more planning for their wedding, but the time they plan trying to conceive or preparing for fertility tends to be quite small,
Yeah.
you know?
Yeah. And I think one of the things that I've certainly seen in my own practice and clinical experience over the years is, somebody may have, depending on their history, had experience with fertility at whatever level, and so they presume that history is what they then carry forward into, their next relationship or what have you.
Mm-hmm.
So there can be sort of another layer of frustration that then is added on when, geez, it didn't go as well or as easy as it did the last time. It can still even be within the same relationship. I mean,
Right.
I'm sure we all have the stories. Think of one of my closest friends who went through struggles with fertility, and went a very, sort of standard path, perhaps, of fertility evaluation and infertility treatments, and really went, deep into a lot of that. Uh, Finally, we're able to conceive through an in vitro process. And then as soon as that process ended, presuming that that was it, that any further, and then of course, where the story goes,
Right.
twins naturally, 4 months later, and then 8 months or after that birth, twins again. So a family
Oh,
that had
wow.
struggled so hard, a couple that had struggled so hard to get to pregnancy, and then the next thing they've got 5 kids under the age of 3, and they're like trying to figure out, it's like the Talking Heads, song of, how did I get here? Like, it was just a moment. So we've all certainly seen that. I know as well from my own experience, the rough numbers kind of used to break down into sort of half, or well, a third, a third, a third. So a third of fertility problems were thought to be primarily female centric in a couple's scenario. A third might be male centric, and then the other third is kind of where the two meet, and so that they're both contributing a portion of that. Is
Right.
that also parallel with what you've seen in your own experience?
Yeah, I have seen that, that statistic, and I've also seen, 40/40. And I think that we always focus on the female piece of that. And I've worked with women, and we've done the piece and, how's your husband? Oh, he's great, and then we find out later, like his count's low or the motility is poor or some factor, but he was, seemingly healthy. And so I think that part, he is contributing 40% or 50% rather. And
Right.
so it's just as important what he's doing and contributing. Yeah.
Got it. So let's kind of think through maybe a good place to pivot into sort of what is it, what is an evaluation? We talked before about kind of the definition of infertility and sort of the strict criteria being that you've tried for a year and you've been unsuccessful. You make a great point around would love to actually see a couple for evaluation as they're thinking down the road to potential conception and just kind of getting that more preemptive evaluation done. But if we consider sort of both scenarios, are there any substantive differences? Two questions. One is, are there any substantive differences with how you would evaluate sort of somebody who has documented struggled with fertility versus how you might just say somebody walks in and says, I think in a few years we want to start a family? Would the evaluation be different in those two? And then what I'd really love to get into is more some of the specifics around what does this evaluation look like?
Yeah, I think if the testing and the gathering of information and evaluating is happening earlier, there's less urgency because generally you have more time if you're starting earlier. The thing about fertility is that it declines with age, right? And so once you're past the age of 35 and egg quality and the amount of eggs are decreasing, then the testing becomes a little bit more important and you want to find out the more depth. So you might do some more, you wouldn't hold off on some of those testings and give time for things to emerge. So I think the age of the couple really depends on the level of depth of testing and screening. I think that you can do those hormone testings and basic blood work evaluation of overall health for supporting optimal fertility. It should be the same all the time, right? If they're young, you want to make sure that they have all those bases covered so that they can carry it forward. And then later too, you also want to do those things, but you might do more imaging or use more therapies to evaluate, the egg quantities and stuff and of that nature.
So in terms of kind of specifics, what would an evaluation look like? Sort of if there is a standard evaluation in your hands or sort of a preferred evaluation, what are we talking about? What is it, just for those that may not understand? I mean, I don't even understand a lot of it. So, talk me through what is this blood work? Is this, obviously medical history goes into it, I'm sure, but be curious about what is it? What are we really looking at?
Sure. For women, one of the most important things is ensuring that ovulation is happening. That's the most important piece for a female. Is she ovulating and knowing when? A lot of fertility difficulties come because there isn't ovulation happening and the couple doesn't know about it, or the timing is somewhat off. And so for younger women, I love to use this as an opportunity to help educate and for them to really understand and learn their cycle. So we'll use fertility awareness methods so they can track their cycle. I like to use, basal body temperature charting, get familiar with the cervical mucus and all those body signs to see the shifts. And then with hormone testing, that's another really important way of assessing things, especially as the couple's aging. So we look at FSH, day 3 testing would be FSH, LH, estradiol. I like to do AMH as well on day 3. And then later you can assess progesterone levels. So those are the basic sex hormone fertility testings that should be done to see where things are.
obviously, we can do a lot of that on our platform with Let's Get Checked. Is that even how sort of, have you used our platform, or have your patients used our platform at all to do some of that testing?
I haven't, but I'm really excited to share that opportunity. I like that you guys have a more robust profile for your hormone testing. A lot of the companies aren't as robust in terms of the number of hormones. I also, work as a clinical advisor for Kindara and Priya, and so those are apps where we can help to identify the fertile window, see those changes happening, and predict some of those points of ovulation and monitor changes. So that's also another method. But yeah, I love that you guys have those robust profiles.
Yeah, and it's certainly, as a company, we've tried to really stand on really solid clinical scientific grounds, right? So, we want our lab tests to be best in class. We run everything at our own lab with a high complexity CLIA lab. With the advantage that obviously these people or patients can come to us and self-collect their own specimen through finger stick assay and things like that. So they're not having to, go wait in line at a clinic or go sit in a lobby at LabCorp or Quest or wherever for 3 or 4 hours. And so, but at the end of the day, we want that result to be reliable. You make a really good point, though. I think that probably bears emphasizing, which is hormonal levels fluctuate in a variety of ways. They depending on what hormones we're talking about, obviously they may fluctuate, just in a 24-hour circadian rhythm.
Right.
They may fluctuate over the course in a female with menstrual cycle. So depending on where you are on the course of that, they may change. And so I like what I was hearing from you, and I think again it bears emphasis about the idea that it's not enough to just say, well, we drew your blood and your progesterone is X. It's that progesterone being X really matters. That number matters only in the context of when was that progesterone measured during the course of your menstrual cycle or something like that. So you have to have the tools to be able to back that up, if I'm not mistaken.
Yeah, exactly. If you look at the ranges for hormones on a lab sheet, they're quite large because the hormones can be very high at one point of the cycle, and that's great. But if they were very high at the wrong point of the cycle, that would be off. So if it's just a random day test that you just go and get, it means nothing because you have no idea, the relevancy of it. It has to be at these specific time points in the cycle for it to be, to give you really information and feedback.
And so kind of going back to what you were mentioning earlier, that perhaps one of the first starting points in the evaluation is around the idea of making sure that ovulation is occurring. Mm-hmm. Practically speaking, besides some of the things you mentioned, basal temperature, cervical mucus, things like these, mm-hmm. are there markers that besides those or in addition to those, how would somebody know, yeah, I am, or more importantly, perhaps I'm not, and now I need to get a little mm-hmm. deeper in the weeds? How does that work?
Yeah, there are signs and symptoms, like we said. You can look on ultrasound. That's not a very practical thing to do, to go in and every month and confirm with ultrasound. Most of the times what we're doing is looking at progesterone levels. So 7 to 9 days before the menses are expected, you would test your progesterone levels and be able to evaluate, if they're high and present, that's an indication that you've ovulated. If they're not high, you have not ovulated or the timing is off. But that progesterone luteal phase, the second part of the cycle, testing progesterone is how you confirm ovulation with just basic testing.
Got it. And if we kind of continue down that path, so let's say somebody goes down that path and ovulation's confirmed, mm-hmm. what's the next? I suppose if ovulation is not confirmed, then maybe it needs to get a little more in-depth ultrasound imaging, and I'm sure there's a whole avenue of evaluation there. But for somebody who, as near as one can document, it appears they're ovulating correctly, what would be the next evaluation that should occur?
Yeah, I think the day 3 testing is really important. The FSH, LH, estradiol to check out the egg quality and egg reserve. might want to explore areas outside of the sex hormones. So check the thyroid, check blood sugar, cholesterol levels, and I like to have the woman guide me based on what other symptoms she's presenting with. So, is she fatigued? Does she have digestive issues? And so there might be some other clues that the body's telling us that could be impacting her fertility.
Yeah, I'm really interested in this notion of kind of looking a bit more holistically about their overall health, because I think what you're mentioning here is the idea that if you've got some other underlying condition going on, like hypothyroid, perhaps it doesn't even have to be true diabetes, but even a borderline diabetic that might be detected on an A1C blood test, right, where you are able to track and document that perhaps they run a slightly higher persistent blood sugar level. If I'm not mistaken, those kinds of conditions can certainly be able to impact fertility. And so if we can identify those at the right time, the addressing the fertility may really require, let's get the thyroid tuned up, let's get your blood sugar tuned up, diet, what have you. Is that true?
Oh, absolutely. Yeah. If you're hypothyroid, you're more likely to have a miscarriage or just not be able to conceive. So, fertility is not just isolated to the ovaries, it's the whole body, right? If the digestive system is really inflamed and there's, dysfunction in the immune system, the blood sugar's irregular, that, all of those things are going to impact the health and overall quality of the eggs and that whole process. Like it's all one swimming pool, right?
Yeah, no, it is. And again, it's probably the detriment of what we've done traditionally in healthcare, where we tend to look at the one portion of the swimming pool and we don't necessarily look at the whole ecosystem. So
right.
I get what you're saying. And I think it's really a good point. Are there common themes that you tend to see in your patients? I mean, is it that borderline, blood sugar, which maybe then pins back to maybe some borderline obesity, and so getting diet under control or exercise, implemented, or is that a theme? Is smoking and some of that a theme? Like, what are the common areas? Like, I'm going to use a word that probably I shouldn't use in a fertility conversation, but what's the low-hanging fruit here that people can consider addressing in their own lives?
The most common thing that I see in terms of, endocrine imbalances is PCOS, so polycystic ovarian syndrome, which is really commonly caused by imbalances in blood sugar and elevated insulin levels. It's really common in our population, unfortunately. And I think, things that contribute to these most common imbalances in fertility things are the lifestyle patterns that we see in society. So, processed foods, high glucose foods, inactivity, right? And then stress and sleep. And then for, our fertility as a society, I think we can't ignore the impact of environmental chemicals that we're experiencing. There's, studies showing sperm counts declining over time and testosterone levels going down. And that's impacting the female as well, which is related to PCOS. And so, what are we using in our homes to take care of ourselves? How many chemicals are we putting on our bodies each day or consuming in our food? So I think that those things play a really big role in fertility. So I go to great lengths to help counsel my clients to start making some of those changes. And those lifestyle pieces, how do we manage stress, right? What do we do to do that? Do we, scroll on Netflix or, do we have these sort of exercise practices and sleep patterns that support fertility? All of those things are so essential. And you want to have those foundations in place so you're not, a parent who is so stressed out and overwhelmed and doesn't exercise, right?